Good afternoon. I'm Vince Kinsler, the President and Executive Director of the Parkinson Association of Greater Daytona Beach. I'd like to welcome you all today to our second in a series of 3 interactive webinars dubbed You, Me, and PD, with today's program titled Directional Deep Brain Stimulation for Parkinson's Disease. Given today's current environment and what appears to be our near future on how we congregate and engage in interacting together in an educational forum, this webinar platform is enabling us to reach out and literally interact with and virtually congregate with our Parkinson's community. So until such time we can again gather shoulder to shoulder to directly interact with those that provide us their gifts of education and resources, we are pleased to announce that we will continue to facilitate these type of programs. Although deep brain stimulation surgery has been available as a treatment for mitigating the symptoms of Parkinson's disease for many years, most recently new technology, specifically directional technology, is allowing for a more personalized programming experience and less follow-up surgeries thanks to wireless implantable pulse generators, also known as IPGs. Today, we have a unique tandem presentation of a neurosurgeon who has used this new DBS technology in the first patient he provided that surgery for. Dr. Sanjeet Grewal is a neurosurgeon and integral part of the world-class team of neurosurgeons at the Mayo Clinic here in Jacksonville, Florida. Where literally one of the first DBS surgeries in the United States was performed back in the late 1990s, and over 2,000 DBS surgeries have been performed there since. We are truly fortunate to have access to such excellent neurosurgeons as Dr. Grewal and the team at Mayo Clinic right here in North Central Florida. Dr. Grewal is joined today by his surgical patient, Eric Johanson, who has dedicated over 15 years of his life in the United States military and is a person with young onset Parkinson's disease. Eric was the first patient to receive this new directional DBS surgery at the Mayo Clinic in Jacksonville back in 2019, not that long ago. So that he could help others going through a similar experience, Eric will be sharing his story with Parkinson's disease from his initial diagnosis to life after his DBS surgery. So please join me in welcoming Dr. Sanjeet Grewal and Eric Johanson.
Hey, Eric. I'd like to start by thanking Vince and Christina and the Parkinson's Association of Greater Daytona for organizing this, as well as Aline and Boston Scientific for helping support this. But most importantly, both Eric and Deb for sharing their story with us today. Can everyone see my screen all right?
Yes.
Yes.
Great. I have nothing to disclose. Today, we're going to talk a little bit about Parkinson's disease, the different treatment options, and then we're going to have what I think is the most exciting part of the talk, which is a discussion with Eric and Deb about their story and how they decided to go ahead with deep brain stimulation and how that's affected their life since. Parkinson's is a progressive neurodegenerative disorder, and approximately 1 million people in the United States suffer from it currently. 10 million people across the world suffer from it. The exact cause remains unknown, and unfortunately, the cure remains unknown. We can break down Parkinson's into 2 different types of symptoms. 1 are the motor symptoms, and 2 are the non-motor symptoms. When we talk about motor symptoms, we talk about the rigidity, the slowness, the difficulty walking, the tremors. But a lot of times we neglect the non-motor symptoms, which can be equally as disabling, such as insomnia, pain, fatigue, and bowel and bladder dysfunction. When we talk about treating Parkinson's, we know that aerobic exercise is absolutely fantastic for both the motor and non-motor symptoms, but it can only go so far. In addition to exercise, the first-line treatment is medication, normally some variant of dopamine, because we know that that's what we lose once Parkinson's starts to progress. Once we get beyond the area where dopamine is effective, we get into surgical treatments for Parkinson's disease. Now, I'd like to take a couple of minutes here and describe the differences between what we consider ablative surgeries and deep brain stimulation. Ablative surgeries have been around since the 1930s and 1940s. And what they do is, there's different ways to do it, whether you use a radiofrequency probe to heat up a small area of the brain, whether you use radiation. More recently, we've been using focused ultrasound, so ultrasound beams, or even laser fibers. What they do is they heat up a certain area of the brain and make it non-functional. And doing so relieves some of the symptoms of Parkinson's disease. The advantages of these are they can sometimes be non-invasive or minimally invasive. However, you can only have them on one side of the head, so only one side of the body will be benefited by these treatments. The other thing is we can't fine tune these as your disease progresses. What you have is what you have with these therapies. What deep brain stimulation allows us to do is provide a reversible treatment option that can actually affect both sides of the body because you can implant it bilaterally. But in addition, as the disease progresses over time, we can fine tune it. And now with the directional leads, they give us even more range to really personalize and fine tune these treatments. So what happens when you're in the early stages of Parkinson's disease? And Eric, maybe you can let us know if this was similar to the trajectory you experienced.
Very similar, yes.
It was. Okay, so typically you start with low doses of dopamine, they're infrequent, and they give you a pretty good relief for an extended period of time.
I started with 4 tablets a day when I first started.
Wow, okay. And then what were you on at your peak?
16 tablets a day.
16 tablets a day. And how are the dyskinesias?
They're pretty bad.
How many years did it take you to go from starting at 4 tablets going to the 16?
Well, I started my first symptoms. I started with tablets in 2007, and I got to 16 in 2018.
Okay. And that's a fairly typical thing we see, where as the disease starts to progress, we need more and more dopamine, but at those doses, we start to get the side effects, the dyskinesias. Just briefly wanted to describe the implantation. That's basically a battery that sits right below your collarbone, and you have 2 leads that go into your brain. And these leads are those directional leads that Vince was talking about, which really give us precise control over where to deliver the stimulation. This slide goes over what deep brain stimulation can help with, but when a patient comes and talks to us, what I kind of try to counsel them to is that imagine the best you are with your dopamine. That's what deep brain stimulation can do. So if there's a symptom you're having that's not really helped with the dopamine, it's unlikely that deep brain stimulation is going to help those symptoms. But if there's symptoms that when you take your dopamine get better, the deep brain stimulation will provide you with a longer on time of those symptoms while reducing the dyskinesias. So Eric, I thought it would be good to kind of go through your journey and your and Deb's journey. So maybe you guys can start and tell us when you decided with this first step. When did you guys decide to start thinking about deep brain stimulation?
Well, it started about 2 years ago. I moved to Brunswick, Georgia in 2015. In 2016, I actually got hooked up with Dr. Van Gerpen at the Mayo Clinic as my neurologist. And he recommended that I go ahead and talk to Dr. Weedy about brain stimulation. My wife actually asked the question about it during one of my appointments about, hey, what about deep brain stimulation? Read about that and heard about it before. I didn't know what it was about. So when Dr. Weedy was down low on the low down on the deep brain stimulation.
And had you heard about deep brain stimulation before this, or how did you get introduced to it?
I had heard about it on Google on the computer.
Okay.
But that was it.
And his grandfather had Parkinson's, early onset Parkinson's, and had a different type of deep brain stimulation.
Yes.
Okay. How long ago was that?
My grandfather had it back in 1956.
Okay, yeah. So you probably had one of the original symptoms.
Yes.
Eric's mother is on. Maybe she can send a brief synopsis of what her dad had.
That would be great. Christina, do you know if we can unmute her?
Who, what is her name?
Rita Johanson.
Okay, let me find her.
Is she there?
No, I don't see her.
All right. Try it.
So
He had the procedure where they froze a part of his brain. He's a freezing technique to freeze part of his brain.
yeah,
That's long.
yeah, I think that's similar to those pallidotomy procedures we were talking about. They probably only did it on one side,
Yes, sir.
and he didn't have a battery or anything along with
No.
it. Exactly.
It only lasted a couple of years. Then he's going back to
That's one of the problems with those procedures. They were great, but like we talked about, what happens is as the disease gets worse, there's not much more we can do to fine tune those. And we know the disease progresses over time, which is where deep brain stimulation gives us a little bit of an added ability to fine tune that programming.
Also, the type that his grandfather had was not reversible.
Right.
So that's one thing that was appealing about the type of deep brain stimulation that you guys offer.
Now, may I ask why y'all chose to come to Mayo when you came down? What type of neurologist were you seeing before you moved to Brunswick, and how did you decide on coming here?
I was seeing a doctor up in George Washington Hospital in Washington, D.C. for about 6 years. She never recommended the early onset. She didn't recommend the DBS right then. And then when I moved down to Miami for 2 years, I went to the Cleveland Clinic for a couple of years. But the symptoms weren't that bad then either. When I got here, they got really worse. They got really bad. And so I heard Mayo Clinic was in Jacksonville, and I heard reputation was Mayo Clinic. So I went and decided to go ahead and talk to someone there. But I still didn't know much about DBS until I started talking to Dr. Van Gerpen. He mentioned it, and I looked at it and watched on Google. And then wife and I talked about it, and then she actually brought it to him in the one of our appointments about, hey, what about DBS? And he said, yeah, he'd be a good candidate for it. We'll have him go see Dr. Reedy and Dr. Reedy.
So even when you guys came here, you were both kind of your own advocates for the procedure.
Sure.
That's fantastic. And did you have any concerns when you were thinking about this before you met with Dr. Weedy and Dr. Warren? Reading online, were there anything that?
Well, I mean, when you talk about drilling to your skull, kind of worry about that a little bit, yeah.
Sure.
But yeah, Dr. Reedy and Dr. Warren were very good about telling me about the procedure, all the details, and what it would feel like. And after that, I knew that I wanted a better life and provide for me. So I did a chance to go for it.
Excellent.
I definitely think that. Sorry.
We have a question from an attendee, and it was, how long did you think about DBS before you decided to do it?
10 minutes.
Well, I knew about it beforehand. I did some research beforehand, but yeah, when I finally got told I was a candidate for it, it didn't take long at all, maybe a week or two before I finally said, yeah, I'll do it.
I was going to say earlier, I think it was about quality of life. Eric, because of his military background and he works out still all the time, he was able to keep everything at bay for quite a long time just by taking the medication. But a couple years back, it started to be to the point where it was affecting his quality of life with the dyskinesias, the rigidity. Even just buttoning a button, and he's only 52 years old right now, so it made him feel like he was 100.
Yeah, my primary symptom was bradykinesia, moving slow, and freeze up a lot.
Yeah, I remember you would fluctuate between the bradykinesia straight to the dyskinesia, and then back to the bradykinesia.
Yes, sir.
So you were really, if we go back to this graph, you're really getting to this part.
Yes, sir.
Of that graph.
I lost a lot of weight too because of dyskinesia. You're constantly fighting your body the whole time because the movements, the involuntary movements are occurring. I lost the body with 175 pounds, I think.
Yes, and his normal weight's about 200.
Yeah, I remember when we had you under a little bit of anesthesia, you were sharing stories. I don't know if I'm allowed to share any of those.
Sure.
but you were telling us about some of the things you were doing with the Secret Service, and even with the Parkinson's, you were carrying people up flights of stairs, and I mean, it was
Yeah.
really quite impressive to see what you were able to go through. And we, our goal was to be able to get you back to that and enjoying your quality of life and with your family and your kids.
Yeah, I've been maintaining my career as service still, so it's good.
That's awesome. I still have my badge, by the way. Very proudly. That's very cool. So why don't you tell us a little bit about when you first met with Dr. Weedy? Because I think the first part, when I think about the DBS surgery evaluation, is meeting with a movement disorder neurologist, someone who's really focused on whether you're a candidate for deep brain stimulation or not.
Yeah, we had a sit down with Dr. Reedy after Dr. Van Gerber introduced us, and he talked about the procedure, pretty much like he said about the old way to do it, and with the new directional way it worked out. What to expect as far as the surgery itself, and then what to expect as far as all the pre-work that I do at the psychiatrist and the lab and all that kind of stuff.
Exactly. So we can talk a little bit about what the pre-workup is. So like you talked about, there's neuropsychometric testing. How
Yes.
long was that? I
It
know
was 4 hours long.
Yeah.
Long time. There's a lot of stuff. A lot
Yeah.
of math and memory stuff, and fortunately, my cognitive was pretty good, so I was able to remember everything and do very well with that stuff.
Yeah, and that's one of the requirements in terms of us going ahead with deep brain stimulation is it becomes harder if the cognition's getting poorer. So the fact that your cognition was quite good made you a better candidate for it. We also did an MRI, and the MRI has two purposes. One is for us for surgical planning so that we can visualize everything at the time of surgery as to where exactly to put the leads. But the second is to make sure that there isn't anything else that's potentially causing these symptoms.
Right.
So, yours was completely clean. It was what we expected from Parkinson's disease. And we used that to plan your surgery. So you met with Dr. Weedy, and then you met with Dr. Warren. How in sync were the two in terms of what they were telling you, or?
Well, very much the same. It was almost just like a mirror to each other. And they were just told the same stuff that we told us. So.
Yeah, they've been doing this together for 20 years. So they've been excellent partners and mentors for me as we go through this. But we kind of do surgery the same way every time and try to counsel the same way every time. Deb, when you had those meetings, were there any concerns you had that hadn't come up before when you guys were searching online and going through the thought process? Or were there any questions answered that you'd like to share with us?
I think a lot of questions were answered. I didn't have a fear. I felt we were led to a certain place, and I've said it before, our faith in God and my faith in you all, what you could provide, definitely outweighed the fear of the possibility of what could go wrong. We felt that it was, for us, a 90% chance of extreme success, as opposed to where he was. I was a hygienist for a long time, so that's all I thought about is how do I keep him completely clean so that it doesn't get infected, and I wouldn't let anybody touch him, right before surgery. But I didn't have fear.
Yeah. You guys definitely settled any fear we had. Very good.
We appreciate it.
I felt like I was at a high-end hotel when we were at the Mayo Clinic. I mean, everything was very, very nice.
Oh, we appreciate that. Yeah. But let's move on, I guess, unless there's any questions about this phase, we'll move on.
We have a few questions that go along with this phase. So one of the first questions is, how long was the process between deciding you wanted the DBS surgery and until you had the surgery?
It was about 7 months total wait time until they had availability for the surgery itself. I had a meeting with Dr. Weedy and Dr. Ware in probably about June of 2018, and I remember my first surgery in February 2019.
Once you do come up on the list, though, you feel like you're waiting forever, and you're not. It's actually pretty quick.
Yeah.
And then once you start the process, that was fast.
Pre-work stuff was done about the same week before the surgery. Yeah.
It was fast.
And then what makes you a good candidate or a not so good candidate? And as you mentioned, Eric was a good candidate because he had good cognition. So is there any other things to watch out for that would make somebody a good or not so good candidate?
Yeah, I mean, there's in general, we like to see that you've responded at some point to dopamine. So if you haven't ever responded to dopamine, it's unlikely that you're going to get a lot of benefit from deep brain stimulation. So that's one of the first things we look at. In addition, we look at where you are on the spectrum of Parkinson's disease. So Eric was very much on the motor spectrum of Parkinson's disease in the sense that he had the dyskinesias and the bradykинesias. We're very good at helping with those. But there's other people that are on the other spectrum where they have a lot of the non-motor symptoms of Parkinson's disease, like the insomnia, the fatigue, and they don't necessarily have the bradykinesia or the tremor. It's less successful in those patients, even though currently we do have trials and we have a lot of interest in trying to improve deep brain stimulation for a lot of those things. That's all experimental right now and in trial phase. So when we strictly try to see who's really going to benefit, it's a person who doesn't have a lot of cognitive problems, who has a lot of motor symptoms, that initially responded to dopamine, but now they feel like they need to be taking dopamine more frequently with larger doses, and they're starting to have side effects. And Eric kind of fit that bill just perfectly.
That is it for the question.
Dr. Grewal, this is Vince. I have a quick question. I'm a little digressing here.
Sure.
You mentioned the neuropsychiatric testing, the 4-hour one. Is there a specific name of that test? And is that for all brain surgeries or just DBS?
So that is something we do as a baseline for all patients that have a neurodegenerative disorder. So anyone with Parkinson's, anyone with any of the dementias would also get this, as well as all of our patients who get epilepsy surgery get this. Now the neuropsychometric testing, that's a broad term. Within that, there's multiple tests. I'm sure, Eric, you went through like 5-10 different tests.
At least, yeah.
Yeah. And those are all basically tailor-made to each patient. So you meet with our neuropsychologists and they establish a baseline. And the reason we do that is as the disease progresses, you can start having worsening of those symptoms. And part of our goal is to try to see if we can improve those symptoms and change your stimulation so that you're not having as many of those neurocognitive problems, as well as try to delay the effects of those. But to do that, we really need to have a thorough baseline, which is the point of developing these neuropsychometric tests. Vince, did I answer it for you? Hello?
He's muted, but I thought that was a good answer, Dr. Grewal.
All right, thanks, Elaine. All right, so we'll move to the next phase. So Eric and Deb, do you guys want to share with us kind of that week before surgery, what your experience was? When did you guys come in to see us, and what all did you have done?
I can't remember the day it was, the week it was, but came out the Monday.
I remember you dropped me off at the airport. We went in and dropped me off at the airport. I just remember joy we were so glad that he was a candidate and that we're on our way.
Yeah, as far as the week before the surgery, after I had the labs and the neuropsychology test done, the proof for everything, the MRI was done. Then we had to prep the night before with the cleaning and clean myself with the pads for that.
Right.
And the next day, we went into the hospital like at 6 in the morning. Early in the morning, you could go in there early in the morning. And they took us back to the back, and we had got myself probably put my robe on, and patient's gown on, and went through the IVs and all the prep for the surgery. And then the neurologist came in, the anesthesiologist came in and talked to me a little bit and introduced himself and make sure that he was near side of the head. He's going to be putting surgery going to take place on. And Dr. Waring came and talked to me, and he came and talked to Dr. Grewal. And then went for surgery.
Okay. Yeah, so it's kind of, I'm sure, a little exhausting those like 2 days right before surgery, because we have you meet with our anesthesiologist. We have all your lab works tested to make sure there aren't any infections. You don't have any bleeding problems that would make surgery unsafe. You have the imaging, which we review and plan with surgery. And then there's different ways we can do deep brain stimulation. So because of your dyskinesias, we wanted to do you awake so that we could stimulate at the time of surgery, and we'll talk about that a little bit. But there's also other ways we do it. For example, if you didn't have the bad dyskinesias, we could have done this, the surgery asleep. We have an intraoperative MRI suite, which allows us to put the leads in while you're asleep. But the advantage of it being awake is it allows us to test and make sure exactly that we're getting the benefits that we want for you. So you came into the operating room, you met the nurses, the anesthesiologist. Do you remember us putting the head frame on?
No, I think I was asleep at the head train portion of it. When waking up, I had this pressure against my skull because of the little screws you have on there. Pushing my head, so I remember feeling that. Your head's kind of locked into a position by that hail on your head. So.
Exactly, yeah. So and what that head frame allows us to do is two things. One, it keeps your head still and fixed while we're doing the surgery, so there isn't any movement, which, you know, for you is not necessarily that big of a deal, but for some of our patients who have a lot of tremor, that actually makes a big difference.
Sure does.
But in addition, what it allows us to do is it gives us a reference as to where all the nuclei of your brain are relative to that head frame. So it's what allows us to position and plan for those leads. So what happens is you come in, we give you a little bit of anesthesia, make you sleepy, put that head frame on, and then you go down to the CAT scanner. I don't know if you remember going down to the,
yes.
And then when you come up, meanwhile, Dr. Weedy, Dr. Waring, and myself are in that back room. And what we're doing is we're planning your implant. So we're looking at your MRI, we're looking at the CAT scan, and we're deciding exactly where we want to put that electrode, but also the trajectory that's going to be the safest to get the electrode where we want it. Then you come onto the actual operating table. And then what do you think for you? I mean, it'd be interesting for me to hear, what was probably the most uncomfortable part of surgery, or the part you wish?
Probably when you do the drilling in the skull.
Yeah.
You don't feel any pain, but you just feel the vibrations. Your head shaking a little bit.
Yeah.
The vibrations of the drills going into your head, your skull.
Yeah.
That was like a portion.
It's interesting. I think I would say probably 80% of patients say that that's their least, you know, enjoyable part of surgery, if surgery can be enjoyable. But yeah, like you said, the bone doesn't have any pain receptors, so it's not pain, but you feel the vibration of the drill, which can be uncomfortable. That lasts about 10 to 15 seconds. And then what we do is we put the lead in. Do you remember Dr. Weedy testing you when you had the lead in place?
Yes, I do. In fact, when I put the lead in first, and I guess you guys started adjusting or fine tuning it.
Yeah.
I could tell my eyes started getting funny. They started flickering back and forth and moving back and forth. And I didn't have motor control of my hands very well. He was holding my hand the whole time, and he was talking to me the whole time. And you got to turn it back, and I got it just right where my eyes are back to normal, and I'm good to go.
Right. And that goes back to the advantage of this being reversible. That, you know, anything we get where we're getting an effect we don't want, we can instantly adjust it and fine tune it.
Yeah.
And you know, that's one of the big advantages of deep brain stimulation compared to some of the other techniques that we've used in the past.
For those out there in the audience that are thinking about doing it, you have Dr. Reedy, and they're staying with you the whole time, holding your hand, talking through it, being very supportive of it.
He's a very calming force.
Yes.
And an excellent partner from my standpoint. For you, Eric, I believe you had the battery implanted the same day, correct?
Yes.
Okay, so this is different for everyone, but in Eric's case, basically once we were happy with where the lead was, and Dr. Reedy tells us, yeah, this is where we'd like it. We're getting good effect and not a lot of side effects. We lock the lead into place, and you go to sleep. And then I'm going to come back to this slide here. So that's the lead part. Then what we do is we tunnel this extension under the skin and hook it up to the battery. So when you woke up, you were ready to go. But I think we programmed you the following morning, if I remember that correctly.
Yes, sir. You and Lane came and programmed me the next morning.
Okay. So do you want to, I guess before we move on to the programming, any questions about the surgery for anyone?
There was just a did the head frame hurt question.
No, you can feel the pressure. It didn't hurt. You feel the pressure. Actually, it didn't hurt till after the surgery was over with, and you have to remove the head frame itself. So you feel the little points with the screw into your head. That's about it.
Sounds like lots of pressure.
Yes, lots of pressure.
Dr. Grewal, I have a question regarding the pulse generator, the battery. I was always under the understanding that that was a secondary procedure, and it usually occurred about 2 weeks after the initial surgery, and it had something to do with Medicare or reimbursement. So is there some clarity there?
Unfortunately, that is correct. It's all related to what your insurance will allow us to do. So Eric was younger and was not Medicare, so his insurance approved us to do it all in one setting for him. But Medicare requires us to do it separated by at least 3 days. And so basically you have your implant, and then usually in our institution, it's about a week later that you have your extension and pulse generator. Now, there are exceptions to that. For example, if someone's on blood thinners, we would do it all at one time, and we can apply for an exemption because we don't want you to be off your blood thinners for an extended period of time. But in general, Medicare requires us to separate those two procedures out.
Excellent. Thank you for clarifying.
There's another question that just popped up, and this attendee's friend had her leads put in different months. Why would that occur, and why not at Mayo, but maybe somewhere else would do that?
So that's actually what happened to Eric as well. And that's that's kind of a center by center choice. And there's a little bit of debate as to what's better, because it is nice to have both leads placed at one time from a patient standpoint. And from our standpoint, we're already there. Placing a second lead is not that much extra work to do. The thing about the brain is the brain doesn't like you to do things on both sides of the brain at the same time. So if you put in leads on the right side and on the left side at the same time, you're trying to recover from brain surgery on both hemispheres, which has implications in terms of your cognitive effects, how long it takes you to get back to normal after surgery, how quickly you bounce back. And then there's a few other technical things that our experience has shown that it's safest and more efficacious when you do these staged and you wait at least 3 months between one side and the other. And what it allows the brain to do is recover from the first surgery and get back to normal and then get exposed again.
And also, you don't have to have both sides done. Eric's Parkinson's was mostly affecting his right side. So he had the left side done. And then once a few days later, he's like, wow, I actually do feel it a little bit on my left side now. I didn't even realize it was affecting the left side as much.
Yeah, absolutely. So in our 2,000 patients we've done, only 40% have gotten the second side done. So that means 6 out of every 10 people are just content with having the one side done. And that saves them from a second side surgery.
That's all the questions, so you can continue.
Okay. So the one of the final stages is the programming and optimization. So one of the advantages of doing the testing intra-op is it gives us the settings that we know are going to work for Eric right when we're done with surgery. So the next morning, Eric, I don't know if you remember how long it took Elaine and I to program you, but our typical is like 5-10 minutes. And I don't know if Elaine remembers either, but it makes it much quicker to program if you can test intraoperatively, because we kind of have an idea, or at least a ballpark of what's going to work and what's not going to work. And then how many times have you had reprogramming since surgery?
I've gone back once since I had the first surgery and once after the second surgery, twice.
All right. And I can tell you guys that's very different than even our past experience. And part of that is the directional leads. So what it allows us to do, so this was, Eric, this was your implant. Your lead was implanted into the subthalamic nucleus here, this almond-shaped nucleus. And what you can see is right here, just lateral to it, these are what we call the internal capsule, or the fibers that control the motor to the opposite side of your body. So if you remember when you were getting those loss of control in your hands and the eye movements, it's because you were getting stimulation of this capsule, which is just a millimeter or two away from where we want to be. So what the directional leads allow us to do is really, so you can see the red is how we're stimulating. So we can stimulate like a full circle, but we can also say, you know what, we don't want to stimulate as a full circle. We want to stimulate just like a half circle like that, and point it towards your efficacious standpoint and away from where the symptoms are. And that ended up being really helpful in programming your leads. So one of the advantages of the directionality and why we didn't have to program you multiple times. The other thing we do at Mayo, and I would say most large centers would be doing now, is we work with our radiologist. Eric Middlebrooks is ours. He's unfortunately unable to join us today. But for each of these cases, what we do is we actually do a kind of a simulation model where we look at where your lead is and we try to predict what the best programming is going to be based on the simulation model. And that's what we start with. So when we start with that, there's very little we have to change to get you to exactly where you need to be. But that's one option, to come and have us, since you were already established with neurology here, that's why you had your neurology follow-up here. But there's plenty of people who, if they're traveling from somewhere else, would rather have their neurologist at home continue to program them, which is very reasonable. And I would say most neurologists feel comfortable doing that. But I know Dr. Weedy and myself and Dr. Werner are also happy to talk to them about what we saw and, see if we can help them improve it in any way as well. How long was this when so you came back and probably saw Amy, who's our DBS nurse. That's probably a little bit longer of a session. She usually spends about an hour or so fine tuning.
Yeah, 45 minutes an hour, yes.
And what were you fine tuning? What symptoms were you having that you were fine tuning versus?
A little bit slow moving, the bradykinesia was still there.
Okay.
Barely. I mean, nothing significant. It was more like,
let's try this out and see where it goes. If it goes a little further, because that feels so good now, I'll see if I can go a little further with it and see what happens.
Yeah.
So when you and Elaine came in the next morning after surgery, it was like instantaneous for me. It was like,
yeah.
other person.
Yeah, most people might not realize that it's literally like watching a person be healed instantaneously. You know, as soon as you turned it on, we watched as Eric, I think the rigidity was the first thing that went away, and his movement, because he had a lot of movement because we had him off of the medication, I think maybe just a little bit after surgery. So he had a lot of movement, and it just, his toes uncurled. I mean, it was really pretty amazing to watch within a minute.
Yeah. And how has life been since?
Awesome.
I like to hear that. That's a win.
Yeah. I got my life back.
Oh, that's fantastic. And you know, what's nice with these new batteries is it's 15 years before you have to change them, at least. How's the recharging? Is that something
I charge usually once a week, but I find that I never have them go below the actual display shows 3 bars for full. I usually go below 2 bars before. It's been 2 bars will have better the whole time. So I just recharge every week, once a week. I just sit there on watch TV, put the recharge in the little holster, and then let them charge.
Okay. And how long do you recharge for?
Probably about 45 minutes.
Okay.
And he'll go without a shirt on at like the beach or whatever. I mean, you can see it, but it's not like, most people never even notice it.
Yeah. Yeah, the new batteries are quite thin, and as long as you position them right, I think for the most part, not too noticeable. That's awesome. And you're still working out and doing the things.
Still working out. I had knee surgery not too long ago, so I can't run right now, but I still ride bikes and do other stuff, elliptical training, and I still lift weights and do CrossFit circuit training. I do yoga as well for my stretching and for the flexibility.
What are some things you wish you had asked us before surgery? Any questions y'all can think of, or for people who are considering it to really ask or try to understand for themselves?
I can't think of it.
I think you guys are very thorough. I mean, there's not a lot to consider when things go well. I mean, when they go well, they go so well that you're in disbelief that it's going that well. And actually, when one little thing goes wrong, you're like, it's not working. You get real panicky, but it's just a matter of tweaking it. With his knee surgery, we've noticed any kind of real pain affects a person's body who has Parkinson's, even with the DBS.
Yeah, absolutely. And, you know, I think the next 5-10 years of deep brain stimulation, there's going to be a lot of work on trying to sense those changes in the body and trying to, on the fly, adjust your stimulation when you have those changes, because we know your body is not at a steady state. Throughout the day, it changes up and down. And I think that's going to be kind of the next frontier.
On my medication too, I'm down to like 2.5 tablets a day versus 4 or 16 before.
Wow.
I'm down 2.5 tablets a day.
I mean, yeah, you are a wonderful example of what the surgery can do. And, you know, both you and Deb, we really appreciate you guys sharing your story with us. Anyone have questions for any of us?
Eric, do you have any regrets?
No, I wish I could have done it earlier. I wish I could have done it earlier, but no regrets at all.
And then do you plug your batteries into the wall to recharge?
No, they use these little rechargers that you put inside a little holster you put in your neck, and it holds it over the top of the bat, and they recharge that way wirelessly. So you plug it in the battery.
And Dr. Grewal, if a female was thinking about getting DBS, and you know, as females are a little concerned about their appearances, how would they would shave some of their hair? I know that that's a concern for some women.
Yeah, so it's also a concern for us. We really try to shave as little hair as possible. Eric, I don't know if you remember how much of yours. Yeah, you can. I don't know if you guys can see Eric's. He's clearly healed now, but
Yeah.
we just shave like a very thin strip, less than like a pencil wide. So most people can never tell that you've had surgery up there once you heal.
I think it would be less noticeable with a woman because, you know, you've got hair that can cover it.
Exactly.
You'll feel the bumps there on your skull before they put the epoxy to close the hole in your skull. But is that it?
Yeah.
Here they might feel it. It's blonde on this.
And same thing with the battery. When for women especially, we try to basically line it up with the collarbone, so that you can still wear a V-neck without the battery showing. So believe me, we understand and try to be as cosmetic as possible. Great. Unless there's any other questions, I think we're at the end of what we wanted to talk about. That's my email. If anyone ever has any questions, feel free to reach out to me anytime. Eric and Deb, thank you again for spending this time with us and sharing your story, and for allowing us to help take care of you.
Thank
And
you.
Thank you.
I'll give it to Vince.
Yes, thank you, Dr. Grewal and Eric and Deb Johanson. What a wonderful presentation. You provided attendees full context of what an individual can expect from DBS surgery. I'm certain your presentation has eased the minds of those that are considering DBS. This will conclude today's program. Thank you, everybody. Appreciate it.
Thank you.
Bye.
Thank
Bye-bye.
you, everyone.